From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we'll be discussing the article, Implementation and Effectiveness of an Enhanced Recovery Protocol for Children Undergoing Surgery, the ENRICH-US Stepped-Wedge Cluster-Randomized Trial. We are here with two of the authors, Dr. Mehul, Raval, and Dr. Jane Holl from Northwestern University and University of Chicago, respectively. Thank you for joining us today.
Thank you for having us.
Today, we're talking about enhanced recovery protocols in children. And first, I'd like to start talking about what we mean when we say enhanced recovery. Some of our listeners may not be familiar with that term, and also a little bit about why you decided to study this specifically in children.
Yeah, thanks, Jamie. The concept of enhanced recovery is something that's not really that novel in the adult surgical world. But just to give an idea and a flavor of some of the elements of enhanced recovery that we're talking about, the paradigm is that we can help hasten the recovery after someone's having surgery by looking at a couple of different domains or elements that span the entire care continuum from before surgery and in surgery and even after surgery. So an example of something before surgery is you've probably heard the term nothing to eat or drink after midnight or NPO after midnight. And the idea behind an enhanced recovery protocol is that that is actually not really founded in data. It's just been practices that have evolved over time. And maybe with an enhanced recovery protocol, you can allow folks to at least drink clear liquids, sugary drinks, carbohydrate drinks, up until an hour or two before the induction of anesthesia. And that way, people come in more hydrated, maybe less hungry at the time of surgery. And then when they undergo surgery, they don't need as many IV fluids because they're not as dehydrated as they were previously, and their blood sugars are more normalized. An example of something in surgery would be the use of blocks or regional blocks to help pain control after surgery. And so during the operation or immediately before or after it, we can work with our anesthesia colleagues to help deliver some regional blocks that help mitigate the pain. And then after surgery, the simplest one is to get up and moving and allow people to eat and drink right after surgery is over. And so by making all these little changes, we call that bundle an enhanced recovery protocol. And what we've seen, at least in the adult literature, is that it really helps improve outcomes and get people better faster.
Jane, do you want to expand a little bit or expound a little bit on the fact that this hasn't really been looked at before in children and why you think it's important to implement in children?
Well, it's not that it hasn't been implemented in children. It's just that the prior studies often tended to be specific pediatric surgical patient populations and more single institution studies. And our goal was really to try and conduct a study that would be a broader patient population, certainly in terms of age and types of procedures, as well as showing that it can be implemented at multiple sites across the country. Also, we needed to implement it in a large population of pediatric patients. From a statistical perspective, we needed to have an adequate sample size to really show whether or not it was effective.
And that's a perfect segue to talk about the methodology. So this was a prospective type 2 hybrid implementation effectiveness, stepped wedge, cluster randomized by entry date into implementation phase, trial of children ages 10 through 18 who underwent elective GI surgery at 18 different sites over a 5-year period. Can you walk us through a little bit about how you did this study?
Well, there's a lot of layers there to how we designed the study itself. The first thing that's important to understand about a study like this is it's really hard to randomize at the patient level. It's hard to take a patient and say, you're not going to get enhanced recovery. And immediately the next patient, you've built all these systems to deliver an enhanced recovery protocol and turn it off for the next patient if they were randomized not to receive the intervention. And so one of the biggest things that we needed to tackle was to understand that this was going to have to be a hospital level change. And therefore, we needed to randomize at the hospital level. And so what we chose to do is take the 18 hospitals that were willing to participate in our trial and randomize them to one of 3 clusters and really modify or change the time that they spent in the baseline period where they were doing their routine care And then a year of implementation is what they got randomized to in terms of timing. And then that changed the sustainability period or the post-intervention period. And so that trial design really fit well for this type of complex intervention. The other piece of that you mentioned was the type 2 hybrid effectiveness and implementation design. And that was very intentional. And I'll actually let Jane talk about that because I think that she has been teaching me over many years about the value of that.
So the reason why the implementation piece is so important is that if in the real clinical setting we are going to be able to show effectiveness, we need to first be certain that the intervention actually has been implemented and is being delivered to the individuals. And so there is such a need to evaluate at the same time both the outcomes, the effectiveness outcomes, as well as the quality of our implementation. And unless we have adequate implementation, we really cannot interpret our effectiveness outcome. If we don't achieve statistical significance, it may merely mean that we did not implement adequately as opposed to not having an effective intervention.
Thank you for pointing that out because I think especially when we are talking about a research about protocols, how those are implemented and how well those are actually adhered to during the study period is so important. And so you got a lot of patients. There were 597 patients enrolled in this study. Now, for our listeners who may not have had a chance yet to read the paper, can you recap some of your major findings?
Yeah. So the first thing that folks ask about is with a study that's designed in this fashion, did we demonstrate improved outcomes as we move from the baseline phase to the implementation phase to the sustainability phase? And we did see a modest increase in the number of enhanced recovery protocol elements by phase. We went from about 10 or 11 in the baseline phase up to about 14 or 15 by the time we reached sustainability. Interestingly, our study was powered to detect a change in length of stay. And classically, when we talk about enhanced recovery protocols and literature coming out of the adult GI surgery field, we see that enhanced recovery protocols can decrease length of stay by a couple of days. In our study, we actually did not demonstrate a statistically significant change in length of stay just based on the phase of the study. So to Jane's earlier point about wanting to study both the fidelity of implementation as well as the clinical outcomes, what's really fascinating is that when we analyze the data by the number of elements received by each patient, what we saw was that there was a clear inflection point. And those patients that had received 13 or fewer elements of an enhanced recovery protocol compared to those that had 13 or more had a longer length of stay. And so by implementing more robustly, we demonstrated that patients can indeed have an improvement in their overall length of stay, as well as a multitude of other outcomes that are really important, especially for children. And that includes things like the amount of opioids they were exposed to or the postoperative complications. So I have to say that initially when we were analyzing the data, it was a little disappointing. But then as we started digging into the nuances of what we were observing, this is really exciting work.
I was struck by that because a protocol is only as good as what's delivered to the patient. And I think that your findings really enforce that understanding. Because what was also interesting for me, though, and I do think it's important as a parent myself to point out, is that on your first analysis, it didn't show a statistically significant difference in length of stay, but you did have decreased opioid use across the board. And we all know what that means in terms of constipation. We're talking about children on top of that. Constipation is an issue for a lot of children at baseline. So it was interesting to see you're seeing improvements, whether there were 13 or more, in terms of how quickly they got to eat, which again, as parents, that's important for our children, fewer or lower opioid use. And then the other huge takeaway, as you mentioned, was the fidelity of implementation. So, overall, as surgeons, what's your main takeaway? And for me, my big question is, how do we increase fidelity of the implementation of these protocols? These are lessons to take away as an adult surgeon as well. Most of us have these protocols, but like I've said earlier in your data support, the protocols are only as good as we're actually doing them.
So what's important about this protocol in particular is it's not really just a surgeon's protocol, it's the care team's protocol. And when you have all of these different professional disciplines, and as Dr. Raval mentioned, it's across the entire continuum of care. So you've got nurses in the outpatient setting, nurses in the inpatient setting, anesthesiologists, surgeons. It's a system level protocol. And that's probably why it is so difficult to implement such similar protocols. There were 21 components. Some were components that the patient and parents really needed to adhere to. For example, as Dr. Raval mentioned, the preoperative, drinking up until 2 hours before you go into surgery. That was a parent-patient component. That was as they were driving into the hospital. So this is why such protocols are so difficult to implement, because you have to implement them across the entire continuum of care with all the different professional disciplines that are involved in providing perioperative surgical care.
And I'll add to that, if I may. There's definitely a piece of this which is to prove that enhanced recovery protocols can benefit children. And I think we've been able to do that. But the bigger lessons, and actually the more exciting lessons, are how do we scale this? To your point, how do we make sure that every patient receives as much of the enhanced recovery bundle as they possibly can? And the lessons we learned on this journey of implementing this protocol have been really eye-opening and fascinating. There's been some really cute anecdotes about, well, gosh, if we want to get the kids up and moving in the hallways after surgery, what can we do? And one of the hospitals actually had some therapy dogs come by, and the kids loved getting out of bed to take the dogs for a walk. And that's really neat, and that's innovative. And when I say it out loud, it's an aha moment. Like, why aren't we doing this more often to motivate our patients? Similarly, the strategies that the hospitals were using were really interesting to learn about. So embedding these things into the electronic medical record was a really powerful tool. And we actually had data in the study that demonstrates that. Having leadership buy-in and a culture that's really supportive to make resources available to ensure that enhanced recovery protocols are implemented is a critical aspect of success. And so our hope is that folks can read this paper and then take these lessons learned and apply them to their own institutions, thus making the work that we've done more generalizable and common across the US and beyond.
To the point, though, about embedding things in the electronic health record, it proved to be very difficult for many of the institutions, even major pediatric children's hospitals. It took months and months for them to be able to get an order set into their electronic health record. So this is clearly an area in U.S. healthcare that is in desperate need of greater resources.
But it's research like this and anecdotes, like you mentioned, that help us, right? Like already we have therapy dogs at my hospital. I've never thought to use them to motivate patients to walk, or help us walk the dog, that sort of aspect. And this is why I love research. It helps our patients, that it's really the spread of ideas that everyone who's reading this paper, adult or pediatric, is going to have one tip or trick that they learn from this to help their own protocol be implemented better. Dr. Raval and Dr. Holl, thank you both so much for joining me today to discuss your article, Implementation and Effectiveness of an Enhanced Recovery Protocol for Children Undergoing Surgery, the ENRICH-US Stepped-Wedge Cluster-Randomized Trial. Our listeners can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Have a great day, y'all.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.